Chapter 9, Health System Navigation, the Role of Health Advocacy and Assistant Programs. So here are some characteristics of the U.S. healthcare system. Right now, it is very disorganized, both the benefits and medical delivery. It's very expensive. We spend more per capita than any other developed country. Technology sophisticated and often designed for provider convenience, not the consumers. And then also the complexity frustrates the consumers. However, the U.S. healthcare system offers limitless options to those who understand how to get them, can pay for them, and can make reasonable decisions regarding their treatment options. So what's the problem? Very few people possess all of these skills. Taking a populations approach can help target interventions. This is to determine patterns and design interventions that are appropriate to particular subpopulations. Every person can be placed in one or more groups according to health-related factors, conditions such as asthma, heart disease, etc., diabetes, hypertension, level of health spending. You've got medications, employer, types of health insurance coverage, as well as providers. So from the health advocacy perspective, there are only two populations of people: those who have a health problem and those who are at risk of getting a health problem. Regardless of which group a person is in, help navigating the healthcare system is useful in accessing the appropriate care at the appropriate time. Now, of those with the health problem, health advocates recognize two types of health consumer. You've got one, that those who can find their way through the healthcare maze, and then of course those who cannot. Those who cannot find their way through the healthcare system are unlikely to reach the best possible outcomes and can incur unnecessary costs. So private health advocacy programs have recently been developed within the last 15 years. These programs are fee-based. They're paid either by the employer or the consumer directly. The consumer pays the advocate directly, or it pays the part of the employer's health benefits. Employer benefit model has gained significant traction. Its value is a means of helping people deal with a myriad of health benefits and access issues. And then also, these programs work in concert with patients' physicians. So there are many professional organizations that help with this advocacy. The growing number of health advocates has given rise to several professional organizations that support the professional development and interest in advocates. We've got the Alliance of Professional Health Advocates, as well as the National Association of Health Advocacy Consultants. So here are some goals of health advocacy programs. The goal is to increase the number of employees enrolled in lifestyle management programs. It's to increase employee satisfaction, increase employee utilization of in-network providers, close a number of identified clinical gaps in care, and also decrease employees' days lost due to personal or family health issues. Having an advocate can actually help people get to the best possible medical outcome. So why do we need health advocates? Well, here are many factors driving that need. Healthcare costs continue to increase. The complexity of the health benefits program, it's a lot. Consumers are being asked to assume a greater responsibility for managing their own health. The medical system is disorganized, and there are a lot of inefficiencies. There are problems getting access to care. There are increasing medical technology and super specialization, and of course many patients aren't going to be aware of that. There's a lot of just information overload. There's so much information for a patient to understand that there's just no way that they can, so they could use a little bit of help from someone else. Increasing focus on quality of care and patient safety, difficulty of managing a parent's health issues, privacy concerns of employees with health issues, and then also nowhere else to turn for help. So from an employer's perspective, health advocacy is definitely a good thing. More American adults get benefits through their employer than any other source. 91% of employers with greater than 50 employees offer health benefits. Kaiser Family Foundation, back in 2013, health premiums for a family of four was $16,351. 2003 to 2013, family health insurance premiums grew by 80%. So the main focus is on cost of health benefits. Regardless of the size of the company, most employers are seeking to buy health benefits within a budget. You know, employers, they want a value for their investment. They also recognize that good health is good for business. Better employee health, less absenteeism, increased productivity, helps to attract new employees and keeps the current ones. And also attempts to constrain costs have resulted in multi-layered, difficult to use benefit programs. So for small employers with less than 100 employees, the health benefit programs tend to be relatively straightforward. Company is usually insured. They pay their premiums to the health plan that bears financial risk. They offer relatively standard insurance programs, so the employee options tend to be fewer. Few staff at employer to help resolve employee issues. So maybe there's only one person that can help employees with issues inside the company. Usually there are no benefits managers or human resource department personnel that can help with this. And then also the benefit brokers play a big role in selling and after-sales support. So here the employees are actually going to depend on their benefits brokers. Now for mid-sized employers where they have between 100 and 1,500 employees, they have mixed of insured to self-insured programs. Companies with usually 200 or fewer employees may decide to be self-insured. Self-insured companies hire an administrator, could be a health plan or a third-party administrator. These people will administer the benefits programs and pay claims using the plan's underlying contracts. They start to see some customization of benefits. Example, they carve out pharmacy benefits to the pharmacy benefit manager. These carve-outs are health benefit services that are provided by a separate company from the company's basic health care coverage. Pharmacy benefits are a common carve-out approach. And then the pharmacy benefit manager administers the prescription drug coverage program. And then also these mid-sized employers they look for health advocacy support for their employees to help with the extra navigational complexity. So now for large employers of greater than 1,500 employees, nearly all of them are self-insured. They pretty much all have a plan administrator, likely to be a health plan, more likely to be a health plan than a third-party administrator for these companies. Customized benefits, best-of-breed approach. Benefit packages typically include an array of programs purchased from multiple unrelated benefits vendors. And then also they have a lot of carve-outs. Some example of carve-out programs: pharmacy benefit managers, we talked about the last slide, mental health manager, disease management, case management, dental plan, wellness programs. So like even for the pharmacy benefits manager, encourages the use of less expensive brand and generic drugs. And then so large employer benefits programs can include more than 20 different vendors that provide some aspect of employee health benefits. So from the consumer's perspective, the preferred provider organization plans, or PPOs, dominate the employer-provided benefits landscape. PPOs that include both in and out of network options continue to be the dominant choice of employees, usually around 50 to 60% of covered workers since 2010. In and out of network benefits introduce complexity, reasonable and customary reimbursement and balanced billing. PPOs are more complex than HMOs, which are only an in-network benefit. This complexity is from unpredictable charges and balance billing from partially or completely out-of-networks providers. So obviously that can be very confusing for these consumers. And then also the high deductible consumer-driven health plans. These plans are paired with savings arrangements such as a health reimbursement arrangement or a health savings account. So these high deductible health plans, they actually encourage consumers to take a greater role in making healthcare decisions and managing their own health. So this actually gives the consumers more of a feeling like they have more skin in the game. The belief is that if people have to spend more of their own money on healthcare, they will spend it more wisely, and then that people will take better care of themselves to avoid preventable health expenses in the future. So here it just says, does having to spend more of your own money make you a better health consumer? Well, some people think that it does. And then also, the data shows people in these plans spend less than those not in a high deductible health plan. Cost tools may be difficult to use or lack features relevant to the consumer's actual health insurance coverage. Here, quality comparisons between facilities and individual physicians are often restricted to certain diagnoses or procedures, or use data that no longer reflect current practice. Consumers need help understanding provider cost and quality measures. And then also, right now, population health outcomes under these high deductible plans as of yet are pretty much unknown. So now from a physician's perspective, some physicians will try to help patients deal with administrative issues to a point. Some physicians, they don't usually have time or the skills, and they prefer to focus on the clinical issues. And also physicians, they don't get paid for helping patients deal with their health benefits information. And then also these physicians, they actually do support health advocacy programs that reinforce their treatment plan and support their doctor-patient relationship. You know, many physicians are actually willing to help their patients deal with administrative issues up to a point. Then they tend to drop out of the process when the problem becomes just too time intensive. Now, from the administrator's perspective, you know, some health plans have enhanced member services functions or their own advocacy programs. Consumers in general do not trust their health plan. 2/3 of consumers worry that health plan cares more about making money than doing the right things for their members. And almost 50% of consumers report having had problems with their health plan in the last year. Health plans may include advocacy support as differentiators in the marketplace. So now we're going to talk about health advocacy as actually an independent service. Here they would actually engage the individual at their time of need, regardless of the circumstances. The independent service would actually encourage those eligible to reach out to the advocate for help at any time they face any issues. In other words, their motto would be, "We'll help with anything." Here, independent services typically opt-in programs. They're not data-driven. They create trusted relationship with the user. Consumers are more likely to engage and to change suboptimal behaviors with trust. They protect privacy. Obviously, HIPAA is a big deal. Here, the users will sign a release form allowing advocates to represent them in dealing with physicians, hospitals, and health plans. Personal relationship between the user and the advocate. The relationship is founded on trust and instills confidence that the advocate's only motive is to get the right answers for the user. And then finally, provide help with any health-related issues facing the consumer. The advocate will give the consumer the correct answer, which may not be the answer the consumer actually wants to hear, but it is the right one. So right now, the utilization of the advocacy programs is about 6 to 10% in the large companies and about 10 to 15% in small companies. And this is greatly influenced by communications promoting the service as well as changes occurring in the benefits plan. Larger companies often have more staff in internal benefits departments to assist employees, so advocacy services pretty much aren't needed as much. Here, the use often mirrors what is going on in the employer's benefits program, change of carrier, plan, design, etc. So when plan designs are altered, benefit questions tend to spike. And then over half of all initial calls are related to an administrative issue, such as bills, benefits, appeals, denials, grievances, and then end up dealing with an underlying clinical problem. Any of these can interfere with the way people are dealing with health issues. And then cross relationships between types of issues. Clinical issues often lead to administrative concerns and vice versa. And then the people who call need some type of care for some medical issues and actually have questions or problems. So here's just an example of the types of reasons people are calling an advocate program. Usually, again, here at the bottom says sponsored by large employers. The main reason people are calling, which looks like just about 25% of the calls are benefits related. They are curious about their benefits. They need some education. And then obviously now we're looking at coordination of care with providers or vendors and then other reasons. Now the other reasons that as they're saying here include elderly care, respiratory, serious injury, podiatry, allergy, sleep disorders, and things along those lines. And then another larger chunk too would be the claims assistance as well as eligibility or enrollment assistance. So obviously there are many calls that are going into these advocacy programs. The majority are for benefit education, but there are a lot of other reasons that people are calling. So what help do consumers really need? Well, they need access to care issues. Here they need to find a physician that has their common need. They need to identify specialists, looking maybe for a second opinion. They're looking for the best doctors and or hospitals. Network participation status. Obviously, if they're with physicians within network, it should be a little bit cheaper. Personal desires and preferences, and also scheduling appointments. And then getting their medical records transferred is another obstacle sometimes that consumers have a hard time dealing with, where Advocate Connect definitely help. So, even advocacy programs, they can act as a single point of contact through this program with the consumer, making connections to other health benefits programs, right time, right place approach to get a patient to the right program to meet their needs. They want to help out with referrals to disease management, case management, also may be involved in disability carriers. And then also too, health advocates can help the consumers provide coordination across a fragmented system. So can we really change a consumer's behavior? Consumer-driven health plans assume that the consumer will be activated to engage in their own health management. Consumers will change their ways that will lower costs and improve quality of care, assuming those that put more into it will get more out of it. Those who perform well in consumer-driven plans may be different from the average individual, inherently more activated. Activated patients have improved health outcomes, and that some may also have lower healthcare costs, more motivated from the start, and are naturally better prepared to manage their own health. And then advocacy programs can help activate consumers and help others who merely are trying to cope with their situation. So in conclusion, the U.S. healthcare system will continue to struggle until we find some means to reduce cost. Employers will continue to respond to the increased cost of health benefits by increasing the amount individuals must pay for their health care, so there'll be increase in premiums. Individuals will have to assume a larger role in managing their own health and making healthcare decisions. And then also health advocacy programs aim to help consumers make more informed and better health decisions, which can lower costs and improve outcomes. So this concludes Chapter 9. If you have any questions, please let me know. Thank you.